Hello, everybody. We're going to move on to our next special populations, which is going to be cardiovascular disease. And we're going to use this special population to really dive in and examine how we can use exercise to make a change in the cardiovascular system over time. So in Unit 1 of the course, we spent a lot of time in skeletal muscle physiology and how we can change peripheral muscles when we implement a specific exercise program. We're going to use cardiovascular disease patients as a vehicle to understand how exercise can change the cardiovascular system over time. Our first case, or the case that we'll use, is a 62-year-old man. He presents to the emergency room with substernal chest pain. They immediately put an EKG on him, and they observe normal sinus rhythm. So if you remember, the rate of your heart is controlled by the SA node. So if someone is in normal sinus rhythm, that would tell the person interpreting their EKG that the SA node is controlling the rate of the heart and the rhythm appears normal. And there's no ST elevation. That ST segment is the portion of the EKG that when it gets deviated from the isoelectric line, it can indicate either myocardial ischemia or myocardial damage. So this is a good sign that his EKG is normal, but he has signs and symptoms of a cardiac issue. So as soon as they do the EKG, they're already drawing blood to try to do an assay on his cardiac enzymes that could be in the blood. His blood work results show a serial troponin. That means they do the test over time, several hours in between. So they did their first blood draw. They measured troponin at 2.2. A time point later, it was at 4.4. And then at a later time point, it was 3.4. So what is this troponin? What are we talking about? Actually, I'm just going to throw you this picture back up because this is a nice little crossover moment. Does this picture look familiar? The troponin that we're talking about is that exact same troponin that we described in skeletal muscle physiology. There is a isoform of troponin in skeletal muscle, and that is that critical protein that can bind to calcium and pull tropomyosin off of actin to reveal the active site to allow myosin and actin to interact. So that same troponin molecule, there are specific isoforms of troponin in the heart. So this would be a protein that normally lives inside of the heart and should not be circulating in the blood. So when you see lab work that says serial troponins, they're actually technically doing measurements of two isoforms. So we have troponin T and I are specific to cardiac cells. And the units on this, if you remember, would be like nanograms per milliliter. So very small. If a person is normal and healthy, you would expect less than 0.01 nanograms per milliliter. This really shouldn't be in your blood. Maybe a teeny tiny bit from just some cell turnover. When the number gets about 5, that's a minor heart condition. And when it's greater than 10, that is a massive cardiac issue. So the cardiac specific isoforms of troponin are highly accurate, sensitive, and specific to determine if myocardial injury has occurred. That is because these are proteins that should live inside of a cardiac cell. The only reason that they are being released in a large enough quantity to be measured in the blood is that cell death has occurred, right? That gunshot, a shotgun to the brain, right? Bits of the cell go everywhere and float in the blood. Unexpected cell death releases intracellular elements into the blood. And because we have this protein that is really only found in cardiac cells, it is specific to myocardial injury. Oh, I'm going to get my sketches off of here so you can see that. So this is a graph of the kind of grouping of cardiac enzymes that can be measured. And we talked about this in pathophys, and we'll go into a lot more detail in cardiopulm, but you can see there are other enzymes they could have looked for, including CPK and myoglobin, but troponin is considered the gold standard. It does take about 6 hours to increase in the blood, and it can stay elevated from anywhere from 5 to 14 days. So if we look at this patient's serial troponins, what does this tell us? It tells us that the heart was damaged, right? He came to the emergency room with substernal chest pain. His EKG was normal, but his blood work is revealing that there was some myocardial injury that occurred. Next thing they did was a cardiac catheterization, and that's actually the image kind of in the background of the slide that you can see. The cardiac catheterization is a long, thin tube that's inserted in an artery, usually at the groin. Sometimes they do it through a vein. It's threaded through the blood vessel until it gets to the heart. And you can do all kinds of things with a catheterization. You can measure pressures in each heart chamber or in specific coronary vessels. You can view the inside of a blood vessel. You can take blood from different parts of the heart or even remove tissue from the heart for a biopsy. So cardiac catheterization is the procedure. What they do while they're in the heart can be extremely varied depending on the questions they're trying to answer. So his cardiac catheterization revealed that his left anterior descending artery was 80% stenosed, and they put in a stent. So if you remember an angiography with stent, they thread a balloon up into the vessel where the atherosclerosis is. That balloon has a metal wire mesh around it. When the balloon inflates, it stretches the wire mesh. They deflate the balloon and pull it out, and then the stent is left behind. This wire mesh to help keep that blood vessel open is left behind. So they basically kind of take the atherosclerosis, smash it into the walls to try to recreate as much diameter of the vessel as they can, and then they leave the cage in to help keep it open once they leave. So from this, the patient is diagnosed with an anterior wall MI. Anterior wall because the left anterior descending artery provides the blood supply to the anterior wall of the ventricle. So that's where the myocardial damage happened. When we say he was diagnosed with a myocardial infarction, kind of what's the differential diagnosis there? What else could have been happening? Substernal chest pain. One of the big things that was possible was just unstable angina, right? That is when you have a critical insufficient amount of blood supply where there is a mismatch between supply and demand, causing ischemic pain, but not so much to have any cell death. So the test that was done that truly separated out the myocardial infarction from the unstable angina was the troponins. Because with unstable angina, there would be no cell death, and you would not have expected any of the troponins in the blood. So he was treated with the angioplasty and stent, as we just mentioned, and he was given some drugs. So the list of drugs is in your notes. I strongly encourage you to give yourself a quick self-test here. Pause the video and see if you can write down after each one of these drugs, based only on the names that you see there, what's the main goal? Like, why would they have given this patient these meds? See how much you remember from pharm. All right, let's go through each one. Aspirin is an antiplatelet, inhibits platelet functions. So a myocardial infarction falls under that bigger name, acute coronary syndrome, which most often occurs from an abrupt change in plaque followed by thrombosis. So there's a rupture of the atherosclerotic plaque and the body clots because the center of your atherosclerosis is very thrombogenic. And when the center of those foam cells and the dead material within the atherosclerosis gets exposed to blood, you get a clot. So that's why you want antiplatelet on board, because this patient might still be actively making new clots and you want to decrease the role of the platelets in that clot formation. Plavix is another antiplatelet, same story, same goal. Beta blocker blocks beta adrenergic receptors, so the goal there is to decrease the work of the heart. It needs to heal from the damage that it just went through, so you want to keep it as low functioning as you can, like decrease the work. And the ACE inhibitor is, we'll kind of talk a little bit more specifically. Maybe you got into this in pharm, but it does affect myocardial remodeling. It slows it to allow the heart to return. The evidence shows that patients following MI who go on an ACE inhibitor have a better return to pre-MI ejection fraction. So it helps with the remodeling to restore function of the ventricle. So that one's not as straightforward. So that's the real reason it's on board. If you did do your self-quiz, you probably wrote something about angiotensin 2, which is a vasoconstrictor. So an ACE inhibitor would decrease the role of angiotensin 2 in the system, which would have been a really good access in your brain from what you remember about ACE inhibitors. It's just a little bit more specific use of this drug. Okay, so the orders given were physical therapy to evaluate and treat, and a referral for cardiac rehab. So this patient, at this point, actually, with what the information that you have, does this patient appear appropriate for therapy? They had an MI, which does not eliminate them from physical therapy. Their serial troponins were trending down. That says that the acute injury is, or the insulting injury is over, because further damage is not occurring. If troponins had plateaued or were still going up, that would indicate to you that myocardial death was still ongoing and would be a reason not to do therapy. It's got a normal EKG with normal sinus rhythm. A stent has been placed. From the information we have so far, this patient appears appropriate, and the one thing you want to do before making that decision would be to talk to nursing about how the patient is responding to movement around the room, if there's anything else you should know besides just what you found in your chart. So that's the PT eval and treat piece. Let's talk about this cardiac rehabilitation piece. Cardiac rehabilitation is a big, it's a big program. It's not just exercise and PT. It is multidisciplinary. It involves the medical team. It involves the nutritional team. It can involve social workers. It brings a bunch of people together to try to do a comprehensive approach to cardiac disease. The lifestyle choices, education about the disease, the medical management of the disease, and the use of exercise as treatment. So we will, as PTs, be much more focused on the exercise piece, but once I start talking more and more and more about the exercise, I don't want to forget this very beginning part, that it's not just about the exercise. There's many, many facets to being successful in treating cardiac disease beyond just exercise. So the goals are to limit the physiological and psychological effects of cardiac illness, decrease the risk of sudden death or reinfarction, control their cardiac symptoms, stabilize or reverse the atherosclerotic process that got them there in the first place, and then enhance the psychosocial and vocational status of the patient. Cardiac rehab is divided into 3 phases, phase 1, 2, and 3. Phase 1 is while they're still in the hospital, inpatient cardiac rehab. This can last typically somewhere between 3 to 5 days. So if somebody came in and had a minor intervention, like just a stent place, they might actually only be in the hospital for a day. So phase 1 might only be kind of just a one-time evaluation in the hospital. But if they have an MI, a CABG, a valve replacement, they're going to likely be in the hospital on average around 5 days. So that's where you kind of get that number and the range for phase 1. Phase 2 is immediately referred to an outpatient center. Typically part of phase 1 cardiac rehab is making the arrangements so they're all ready and set to jump into phase 2 when they get discharged. That phase 2 typically lasts around 12 weeks. And then phase 3 is the maintenance phase, which is the lifetime of change that will have to come and be maintained to stay healthy and safe once you have had a cardiac incident. Cardiac rehab is typically going to be referred by the physician as soon as the patient is stable. Mobility is the goal. Get them up and get them moving. So since our patient is still in the hospital, we are talking about phase 1 cardiac rehab. Again, this is going to be a very short window of time to make a change and introduce exercise and make sure the patient can begin exercising safely. This can be really scary, right? This person just had a heart attack, and now you walk in and you're like, okay, let's now challenge the heart with exercise. One thing to consider when you're treating patients after they've had a intervention for a myocardial ischemia issue is that in many ways, the intervention has sort of fixed the problem, right? Before they had the MI, they have had reduced blood flow to their heart for a long time. The day after this patient's myocardial infarction and the day after he was stented, he actually has way more blood flow getting to his heart than he had even before the myocardial infarction. So he could have been, his activity level and exercise tolerance was being limited by the atherosclerosis in some way, shape, or form, even if he didn't have overt symptoms. And now you're walking in and he actually has better blood flow. With the big asterisk, of course, he has had some damage to the ventricle. So depending on the severity of the myocardial infarction, there's higher risk profiles for different patients. So the more minor the insult to the heart, the more aggressive you can be in phase 1. The more severe, the larger the area that was affected by the ischemia, kind of the higher the troponin levels have gotten or information they might have gathered from the catheterization, you might have to be much more careful based on their risk profile. In general, phase 1 cardiac rehab, the goals are get a status assessment. How are they tolerating everything now? Get them mobilized, get them up, and get them moving. You want them up against gravity as soon as they're medically stable to start getting that heart to get it acclimated and start healing. Identify and understand what risk factors they might need to work on to get better in the long term, kind of already beginning to sow the seeds for phase 3, the long-term maintenance phase, talking about initial self-care, discharge planning, what physical activity they can do at home, how are they going to be successful in their ADLs, and then already working to get that referral to outpatient cardiac rehab. So here's our patient. 62-year-old male diagnosed with anterior wall MI. Went through each of these, I think, in pretty good detail. And we are now wanting to start phase 1 cardiac rehab. Would exercise be appropriate for this patient? We said, was there any reason that you wouldn't treat from a physical therapy standpoint? No, this looks really good. Troponins are trending down. He has been stented. His heart has better blood flow than it did 2 days ago. But do you really want to exercise this patient? As it says in your notes, you want to really think through what we're talking about when we say, quote unquote, exercise in phase 1 cardiac rehab. In the lab portion of this course, we've been talking about all different kinds of exercise, and we'll be observing a VO2 max testing where you push somebody to the limits of what their cardiovascular and pulmonary fitness is. It's a formal monitoring of their functional capacity, basically an evaluation of their cardiopulmonary fitness. And while we don't do that in this setting, we do use activity as like a little mini exercise test right at the bedside all the time. So when we're saying we want to go in and exercise, sitting edge of bed could be exercise for someone. And you would see that acute response to exercise. You would see the rise in heart rate, the rise in systolic blood pressure, the maintenance of diastolic blood pressure, increased tidal volume, all of the expected responses to acute exercise, going sit to stand, transferring to a bed, taking a walk either around the room or in the hallway. These are all little mini stress tests. And so you want to be very careful to be monitoring vitals, Any patient who's in cardiac rehab is going to be on the monitor, so you'll have all the information, EKG at your fingertips. You can take BPs super easy, and you can see exactly how the cardiovascular systems respond to this graded exercise test, right? Sitting edge of bed early in the test, going to stand, you've raised the intensity of the exercise. Going for a walk, you've raised the intensity even further. Have they appropriately adjusted to each increase in exercise intensity? You monitor it, you record it, and this is such critical information to help guide discharge planning, return to ADLs, goal achievements for these patients, what's even possible for these patients. It is truly exciting. You're on the front lines and providing the most critical information for some of the decisions being made by the entire medical team, because you're the one going in and doing the stress that truly challenges this system that was hopefully fixed, is maybe the wrong word, but hopefully was just fixed by this stent that you're now getting blood flow to the heart. How well does it tolerate it? So when would we say no to exercise? I kind of gave you a patient that's okay to exercise because it's going to serve my purpose since we need to talk about exercising him. But what is the patient that you say, no, this is not safe. We're not going to start exercise. New or recurrent chest pain in the last 8 hours. Even after a stent, I say the stent fixes the problem. It fixed one problem, but sometimes it reveals others that come up. And so you want to be very careful in knowing what's going on. Where do you get this information? It may be recorded in a chart, but you absolutely have to talk to nursing and ask the question if they've been having any chest pain, because that would be a reason not to do therapy. Maintained or elevated creatine kinase or troponin values. That is something you would find in the chart. If you go to the chart and they haven't drawn them recently, but you think they should have, you might ask nursing, have they just done another draw? You might wait to see the results of that before you make the decision. But if it hasn't yet started to go down, we don't start exercise. That would be an indicative, of current myocardial cell death that's still happening. Evidence of decompensated heart failure. So why are we even talking about heart failure? This guy just had a heart attack. Why am I concerned he's going into heart failure? The portion of the ventricle that was damaged by the heart attack is likely going to have less force generation capabilities, right? That muscle isn't going to be as strong. So if you decrease the strength of the ventricle, what could happen to cardiac output? If you are not generating a great enough force contraction to squeeze the blood out, you can get reduced cardiac output. And I'm sure many things have fallen out of your brain from pathophys, but please, oh please, oh please tell me that if I ask you what heart failure is, somewhere in your brain you immediately just want to say reduced cardiac output. Because heart failure in all of its forms is ultimately reduced cardiac output. So that's why it's on this list. It is a huge risk after an MI that a patient will go into heart failure, and that's something we are very vigilant in watching for signs of. So evidence of decompensated heart failure, what is that evidence? This would be a great time if you want to challenge yourself to see what you remember from pathophys. If you want to take a pause, write down, what do you think is the clinical signs that someone's going into decompensated heart failure? Pause the video and write them down. See what you know. Okay, welcome back. I'm sure you all paused and made a very clear list. What's on your list? Resting dyspnea, right? Heart failure has a lot of fluid that can back up into the lungs. Dyspnea at rest, difficulty breathing at rest. They might have crackles in their lungs, evidence that there's fluid in the lungs. Laboratory evidence like elevated BNP, that's that gold standard of a sign of heart failure. If they're getting high BNP levels, the team is very worried that the heart is failing. Peripheral edema, right? This is all about fluid backing up into the systems behind the heart because the heart can't pump enough forward. Fluid backs up behind. Big puffy ankles, fluid in the lower extremities, all signs of heart failure. Abnormal heart rhythm on an EKG in the past 8 hours. You should be able to get this from the chart. It'll be evidence. You can ask nursing if they've observed it. And then you always check for yourself. When you walk in the room, you look at the EKG and determine if they are currently experiencing any abnormal rhythms. If they are, you wouldn't do exercise, depending on the rhythm. And we're going to go way into that decision making in cardiopulm, but let's just leave it at that for now. So we talked about risk stratification in the first unit. When a patient just comes in and you want to find out, if it's safe to exercise, the ACSM has a specific risk stratification list for patients who have cardiovascular disease. As you can see in this chart, patients are categorized as low, moderate, or high risk. And the top, they say things that they don't have. So if they don't have complicated ventricular dysrhythmias, they don't have angina, they don't have signs of myocardial ischemia, they don't have congestive heart failure. These are all things that have to be absent for the patient to be considered low risk. They have to have the presence of normal hemodynamic response to recovery and exercise. So the expected cardiovascular response to those little mini stress tests that you did would have to be there for them to be low risk. If they had angina or unusual symptoms or even some mild to moderate silent ischemia, that would put them at a moderate risk. And then basically if that list of things that's absent in the low risk is present, they become a high risk patient. Measures of EF is ejection fraction, right? That's of the volume that got into the heart at the end of diastole, how much are they able to pump out? Typical ejection fraction in the healthy, 55 to 75%. So if they're above 50%, they're low risk. You would be getting ejection fraction measurements from echocardiogram or even catheterization measurements. So this would be something that would be in the chart. This is obviously not something that you would be measuring. This is not a vital sign that we measure. And then as the ejection fraction goes down, you get higher and higher risk. Then there's this element of functional capacity, and it's written as METs, greater than 7, less than 5 METs. So I want to dive into this as this is a common clinical language to describe functional capacity. So the top of the next page of your notes defines functional capacity as measured as the maximal volume of oxygen consumed during a graded exercise test. And that's this graph here on the right. As they increase exercise intensity, the body increases oxygen consumption. The reason this is the test of your functional capacity of your cardiovascular and pulmonary system is because these are the systems that all work together to bring the oxygen in, deliver the oxygen to the muscles, and then ultimately deliver the oxygen to the mitochondria to make the ATP. So if there is a problem in any one of these systems along the chain, it will impair the maximal oxygen consumption that the body is capable of, which will ultimately impair your exercise capabilities. So we've already talked about the volume of oxygen, or the VO2, as like the challenge to the cardiovascular and pulmonary system. And we talked about this through the lens of the healthy person. How does the lung do it? How does the heart do it? But you can actually take this exact same measurement as a marker of cardiovascular and pulmonary health. The healthier the system, the more oxygen it's capable of bringing in and using. So this measurement gives you a lot of information on the cardiac, pulmonary, and vascular systems from a standpoint of, are these systems impaired? The ability to measure oxygen consumption and gain this information on how these systems are ultimately making ATP, or ultimately how much work is the body performing, comes from comes from earlier studies that utilize something called direct calorimetry. Direct calorimetry is based on the concept that the conversion of stored chemical energy to mechanical energy actually generates heat. And this is a piece when we did the myosin ATPase, or the actin and myosin cross-bridge cycle. I didn't mention the fact that this conversion generates heat, but the process by which we use ATP and break off that phosphate and transfer chemical energy into the mechanical processes in the muscle isn't an entirely efficient process, and it does release some heat. And so these direct calorimetry measures the amount of heat generated as an indicator of how much total work is being performed in the body. Because it's not as simple as just kind of measuring, how much weight did I ask them to lift and how far did they lift it. That's just the external work that you can see going on the outside. But there is a ton of internal work happening when someone is exercising. The mechanical work of the heart, the chemical work of synthesizing cellular molecules, the transport work right across the cellular membranes. This is all generating ATP, and it's hard to know the total amount of work that's being performed during an activity and how the impact that is on their physiology. So direct calorimetry did just that. They put people in a chamber that was completely isolated, and they surrounded the chamber with water, and then they had them do different activities, in this case, exercise. And they measured how much heat was being performed in a specific exercise. And from this, they were able to estimate the total amount of work that activity required of the body, taking into account all of that internal metabolic work. So we've talked about, how exercise generates heat. We had this whole, thermal regulation piece in the last lecture. But now we're looking directly at the source of that heat as an indicator of how much work is being performed. And while this is very cool, and I'm sure the exercise physiology majors got to hear a bunch of really cool studies they did with these these chambers where they had people live in them for periods of time, do all different kinds of exercises in these. And while they measured the total work being performed in a ton of variety of things, they were measuring how much carbon dioxide was produced and how much oxygen was being taken in. So at the same time they were measuring the changes in heat, they were also keeping track of how much oxygen was coming in to the body. And what they realized was there was a direct association between the two. And that's kind of where this graph that we keep coming back to truly comes from, is the knowledge that the heat produced down here, when we convert chemical energy to mechanical energy, that heat is directly proportional to the total amount of oxygen being brought in, because oxygen is ultimately how we make ATP. So we learned that the volume of oxygen consumed is proportional to the energy cost of exercise. Since direct calorimetry, putting people in a chamber, a completely sealed off chamber that's surrounded by water, this is not easy to do. This is not something we can casually do during therapy. They started to use oxygen as a surrogate for heat because this relationship existed between the two of them. So now we talk about the functional capacity of the system, the total amount of work, as a measurement of oxygen. So that's why VO2 is a measurement of functional capacity. So we historically now do a graded exercise test. We gradually increase exercise intensity and monitor the physiological response. A graded exercise test is often done with a 12-lead EKG to get a lot of information about the heart. You measure heart rate, you measure respiratory rate, and you analyze the composition of exhaled air. What percentage of that air is oxygen and what percentage of that air is carbon dioxide? These measurements give you a really important value called the respiratory exchange ratio, which we are going to talk about in a later unit when we discuss how we actually make the energy in the cell. So I'm going to put a pin in that for right now, but know that these graded exercise tests give this information based on how we're using our gases. The other thing that it measures is the volume of air that we breathe. And this is really where we start to talk about functional capacity. How much oxygen are you capable of taking in? Because the volume of oxygen consumed is proportional to the energy cost of exercise. What is the functional capacity of the system when we gradually increase the intensity of the exercise and measure the oxygen that's taken up? So the measurement that you record during the test is called the absolute VO2. You record the volume of oxygen as the liters of oxygen consumed per minute. And as this gear shifting model would imply, the better, the stronger, the bigger the heart, the lungs, and the blood vessel, the more oxygen you can take in. But the measurement of absolute VO2 has a problem. And the problem is this. These two individuals have very different sizes of their bodies. And it would be very hard to compare the overall fitness of these two little cartoon characters based on absolute VO2 because their physical size is so different. And if we're going to use this measure to interpret the function and performance of the cardiovascular and pulmonary system, we need to be able to compare it between people and have normative data. The absolute VO2 of the guy on the left is going to be greater than the absolute VO2 of the guy on the right, simply because he has a greater volume in his body to take up that air. But if we want to be able to compare the fitness between these two, we want to make that measurement relative to their body size. By normalizing it to their body size, we're really actually thinking about the utilization of that oxygen, because this little guy over here has much smaller body to deliver that oxygen to, and so his requirements will be different. If we make the measurement relative to their body size, then we can compare their utilization of oxygen between the two to measure fitness and health and a number of things. So basically you just divide out their body weight in kilograms, and that gives you the relative VO2 that you can then compare between people. So whenever you are talking about functional capacity measurements as a measure of fitness or as a measure of health risk, cardiovascular health risk, it's always going to be a relative value. That's the only way that number makes any sense. And this number matters to you because it tells you a lot about what the patient's going to be capable of doing. So I like this little illustration on the bottom of the slide. If a set of stairs required a certain physical challenge, and you are comparing someone's relative VO2, and the person on the left had a maximal capacity of 28 milliliters per kilogram per minute, and the person on the right had 35. They illustrate this as like a tank, right? On the left, this little tank, how full of it, how much of your total capacity are you utilizing? If this stair challenge takes this much effort, this much oxygen to fuel the machinery to climb the stairs, you can see that the patient on the left, you tapped much more into their total reserve than the patient on the right. The energy requirement of the stairs is the same, but relative to their total capacity to take in oxygen and use it, that challenge will feel very different for those two patients. This would be, an RPE of extremely easy for this patient because he hasn't even reached the halfway point of his total capacity, where the patient on the left is struggling because he's at 70% of his total capacity just trying to get up the stairs. So using this relative VO2 as an indicator of fitness helps to put patients on the spectrum of what they're capable of and how big is their tank that they are able to access when doing an activity. So we have fitness ratings based on relative VO2 that are different for men and women and also changes as we age. So you can use this normative data to see how fit your patient is based on results of an exercise test that will help give you valuable information as to how big is their tank that they have access to use oxygen to fuel whatever exercise you are asking them to do. So this gets back to this idea of this METS, this function. We just said the functional capacity is the total ability of your system to use oxygen, the maximal volume of oxygen consumed. That's your functional capacity. But what's written on this graph, this chart, is not something in milliliters per kilogram per minute. It says METs. So what is MET? It stands for metabolic equivalent. Basically, exercise physiologists can speak the language of VO2 very well, but that's not very easy to translate into clinical goals, and you often don't take those measurements. We're not, we don't, in physical therapy, we're not measuring the volume of oxygen they're taking in during a physical therapy session. So it's not really appropriate for goal writing. It's not something that's easily assessed, although it's a critically important value that's super helpful. So someone came along with this idea of what if we convert it into something that's much more kind of user-friendly? And they came up with metabolic equivalents. Metabolic equivalents are multiples of your resting metabolic rate. And after many of these direct calorimetry studies that looked at the metabolic work of being at rest, it was measured and determined that on average, our resting metabolic rate is 3.5 milliliters per kilogram per minute. That's the relative VO2 of rest. Across populations, on average, we are going to assume that your resting metabolism is 3.5 milliliters per kilogram per minute. So when you look at that pie chart of all of the energy requirements of our body, about 60% goes to this resting metabolic rate. That is all of the energy demands of cellular processes at rest: ventilation, circulation, peristalsis, cellular synthesis of proteins. This is all happening at rest and does require energy. And on average, it takes about 3.5 milliliters per kilogram per minute of oxygen to fuel that. This does not take into account the thermal effect of food, or obviously the increased demand that physical activity can add to it. So from the assumption that at rest we're using 3.5 milliliters per kilogram per minute, metabolic equivalence said we are going to make that one MET, and then make everything a multiple of that. So one MET is the energy required to fuel the metabolic processes of being completely at rest. 2 METs would be exactly double that, 7 milliliters per kilogram per minute. 3 METs would be 3 times that resting value, and so on and so forth. So they were able then to do all these, they measured all kinds of different physical activity, from occupational positions to recreational things, walking at 1 mile per hour, walking at 2 miles per hour, walking at 4 miles per hour. What was the oxygen consumed? And then they took that measurement and made it relative to this resting value. So metabolic equivalents are how many times above rest does that activity require of the body. And it works well for prescribing exercise, because as the original chart showed, if they can do activities that are greater than 7 METs, they can get up into this higher levels. We know that largely equivalents to, or is largely equivalent to, much higher amounts of VO2. So obviously their cardiovascular system is handling a pretty big load. So in that way, the risk stratification used METs to determine what somebody's capabilities are, how big is their tank that they can take in of oxygen. And you can use it to prescribe exercise by giving patients a chart and saying, your doctor doesn't want you to go above 4 METs. So basically, anything here and up is okay. Everything below that is a big no-no. And it can give patients a lot of freedom to do things that they want to do. Golf, riding a bike, digging in their garden. They can find out exactly what's kind of the equivalent of VO2 and determine if it's safe. Because we as clinicians know how METs are formed relative to VO2, we can actually be able to convert kind of between the two languages. So METS is the clinical language that's supposed to be easy to describe to patients. VO2 is the exercise physiology language, and that's how we talk about how many calories are burned during exercise. And we can go between these two languages to help prescribe exercise relative to the energy demands of that exercise. So here's just a practice question. A 100 kilogram patient performs exercise for 30 minutes at 10 METs. How many calories were burned? So there's a metabolic cheat sheet you can use to solve this problem. And it is based on the fact that METs are equal to, 1 MET is equal to 3.5 milliliters per kilogram per minute, right? Because that's how we came up with the idea of a MET. And by we, I was obviously not on that team. So you can take the METs and multiply it by 3.5, and that will convert that same number that you just got off a chart into a relative VO2. So you can convert from METs to relative VO2, and now you will have a number with the units of milliliters per kilogram per minute. Isn't that cool? So you can easily convert METs into a relative VO2. If you want to discuss how many calories were burned in an exercise, you're going to need to know the actual amount of oxygen consumed, or at least an estimate based on the MET. So we're going to need to convert relative VO2 to absolute VO2. How much total oxygen was taken in? And so since relative VO2 was just simply absolute VO2 per kilogram of body weight, the only thing you have to do, actually let me erase this, the only thing you have to do is multiply the relative VO2 by body weight, BW, body weight, and that will convert relative to absolute VO2. So by multiplying by body weight, you now have the absolute VO2. Or in other words, you have milliliters per minute, which it'd be very helpful to get that into liters per minute. So we're just going to divide by 1,000 to get liters per minute. So with these very simple calculations, just knowing how to get METs to a relative VO2, how to get a relative VO2 to an absolute VO2, you now have an estimate of the liters per minute that this patient took in during their exercise. So when you have the liters per minute of oxygen, you can actually convert that to calories, because 5 kilocalories are burned for every liter of oxygen consumed. Maybe I'll write that out. We've got 5 kilocalories of energy per liter of oxygen consumed. So once you know liters per minute, you can simply multiply by 5, and that tells you how many kilocalories per minute. If you want to know total kilocalories burned during the exercise, you just multiply by the time of the exercise. How many minutes were they exercising? Multiply by minutes, and you get kilocalories of energy consumed during that exercise. So let's go back to our example. We had this 100 kilogram person exercising for 30 minutes at 10 METs. How many calories were burned? Well, if we start with 10 METs and we multiply by 3.5 to get his relative VO2, he was using 35 milliliters per kilogram of body weight per minute when he was exercising at 10 METs. He is 100 kilograms, so let's get his body weight out of there so we can get an absolute VO2 of 3,500 milliliters per minute of oxygen consumed, which is a big number, and we like it much better when it's in liters. So let's divide out 1,000 to convert to 3.5 liters per minute of oxygen consumed. But he wants to know how many calories he burned, right? Because he's got some kind of weight loss goal, I'm guessing. So you can take 3.5 liters per minute and just multiply by 5, because 5 kilocalories of energy are burned for every liter of oxygen. So we have 17.5 kilocalories per minute, but he wants to know total calories. He exercised for 30 minutes, so let's just multiply that by the time of his exercise, and we can see that he burned 525 kilocalories during that activity. Here's another one for you to try. A 140-pound female wants to burn 400 kilocalories per 30 minutes of activity. What would be a good MET level? All this does is it takes the exact same process and goes in reverse. You start with 400 kilocalories and you want to get to the MET level. So let's first just divide out the time so we can get kilocalories per minute. So let's divide by the 30 minutes. So during this activity, she was burning 13.3, the point kind of disappeared, kilocalories per minute. We know that 5 kilocalories are burned for every liter, so you just have to divide out that 5, and you end up with 2.6 liters per minute of oxygen consumption. We're going to want to convert that into a relative value. So let's first get the liters to milliliters by multiplying by 1,000. And we now have 2,670 milliliters per minute. Let's divide out her body weight. 140-pound female, you got to convert that to kilograms. 1 kilogram is equal to 2.2 pounds. So if you divide out by 2.2, you can see she is 63.6 kilograms, which means that she has a relative VO2 of 42 milliliters per kilogram of body weight per minute. To convert a relative VO2 to a MET, you just divide by that resting metabolic rate, which is 3.5, and she would like to find an activity that's around 12 METs. She can go to the graph, look at options of activities that are around 12 METs, and she should be able to accomplish her goal. So I'm just going to break the video here so that it's in a slightly contained length of time. And we're going to go back and apply kind of that risk stratification and really talk about how we mobilize a patient in phase 1 cardiac rehab next time. Bye, everybody.